Sure. Thank you, Abdul Ghani. Thank you for my colleague, the previous speaker. Again, another emergency endocrine subject. بسم الله الرحمن الرحيم. وما أوتيتم من العلم إلا قليلا. I don't have any financial issues. I have some question I'd like to be discussed or addressed to you during my talk. My lymphedema coma. Is there any preventable factor? Definitely there is. So you have to identify them. Then you can save your patient. Is there any early stage of lymphedema crisis or coma? So better to identify them rather than waiting to be further aggressive disease comes and more comorbidity and will be high mortality. Any prognostic factor? Definitely there is prognostic factor. The issue, which is mainly the hot topic about intravenous L-thyroxine, giving orally, what's the update management giving L-thyroxine or L-thyronine, which is the T3, the active form. This will be mentioned during my next few slides and minutes. Starting by the definition, it's a rare endocrine emergency. Result, decompensation of severe hypothyroidism. That means patient should be in hypothyroid state, diagnosed whether recognized or unrecognized hypothyroid state, associated with usually with high mortality rate. Updated definition, it's neglected or untreated hypothyroidism. Also, again, most of the definition, they are mentioning the mortality because really it's a high mortality. Pathophysiology, patient who's in hypothyroid plus the precipitating factor, which will be mentioned later on, they will have low serum T4 and definitely will be low T3, which is the active form. That lead to many things. Fluid retention, then leading to hyponatremia, decrease inotropic effect. Hypothermia per se itself leads to decreased cardiac output. Patient stupor, then there will be decreased mental status, respiratory failure, then cardiogenic shock. In fact, the most hormone being as a leading of the pathology is antidiuretic hormone because this will be going up. We have low cardiac output, decrease the renal flow. So when this is on board, will lead to fluid retention, hyponatremia, hyposmolar status, also hypoglycemia. So all these things can lead to myxedema coma. Mortality, again, as a physician, you are concerned about two things in treating your patient: the comorbidity he will have, and what's the death rate or the mortality percentage. In the past few decades, reaching up to 60 to 70%, but still, again, there is a good national database in Japan, which I will cross to this nice study, reaching up to 30%. Still, it is high. So that means you can lose 1/3 of your patient when they presented with myxedema coma. Recent publication a few years back proved that the mortality is getting lower, 15 to 20%. But again, about 1/5 of your patient, they can die from this entity. Keep in mind, I mean, this what I'm presenting the percentage. It's usually like a case series or case report, because it's a rare disease. But what is the figure I quoted from literature review? Clinical feature. The most common presenting clinical feature among myxedema coma patients is cardiovascular, reaching up to 80 to 85%. They can present with the bradycardia hypotension, but keep in mind, they can present again with initial tachycardia, low cardiac output, and the most important among the changes is the long QT interval, which one of the leading cause of cardiac arrest and worsening the outcome. Secondly, patient they can come with confusion and obtundation, then coma also will be induced seizure or leading to the seizure. Initially, they can go with initial depression, psychosis. That's why the elderly patient, many patients have been missed as they are having Alzheimer's disease or they are forgetfulness. So this is one of the, what you call it, preventable dementia cause is hypothyroid state. Also, hypothermia may be reaching 30 to 50%. They can present with hypothermia, temperature less than 36 or less than 35. So the best way is doing rectal temperature on these patients. Respiratory, definitely most presenting, if you are doing like EPG, you will find hypoxemia, low PO2, high carbon dioxide, respiratory failure type 2. Then they can progress further. That's why one of the standard treatment think a lot of elective intubation among these patients. Gastrointestinal, this is a hyperdynamic the thyroxine is hyperdynamic hormone, so can lead to GI upset, decreasing also the intestinal movement. They can present with paralytic ileus, toxic megacolon, and also, as I mentioned about the ADH secretion lead to fluid retention, which also lead to hyponatremia. Also, hyponatremia itself, it's one of the emergency endocrine cause, whether with hypothyroid or non-hypothyroid. So this is a lady, about 72 years old. When she presented to their hospital with the confusion, obtundation, she was electively intubated. You can see some feature of hypothyroid. Looks buffy, looks pale, which this is one of the cause of anemia, whether normocytic, normochromic anemia, or if there is megaloblastic or fluid deficiency, can be, you will find high MCV, high MCH. Also, maybe you can notice maybe macroglossy as a feature of, maybe if you want to comment further about losing of outer third of eyebrow. So this is the situation. Looks sick lady who present with the myxedema coma. How to diagnose? Still again, there is no global validated diagnostic criteria because of the sudden onset, very rare entity. But usually we should depend as a physician to symptoms and clinical exam without waiting of laboratory result, as mentioned by my colleague, Dr. Al-Babli, that like adrenal crisis, anything you suspect, you should treat, and waiting for further investigation comes up. Also, since there is non-specific, can mimic other condition like septic shock, but keep in mind other endocrine cause, which was mentioned a while ago by Dr. Nasser, could be the storm. So these all like can present with instability, confusion as well. So keep in mind, but many of these can be picked up easily or diagnosed easily by one or two biochemical markers. Precipitating factor, this is what brought the patient per se. They can have purely myxedema coma, but commonly is there is a precipitating factor. So the history, or you should have a low index of suspicion, and should ask quickly the relative. Usually, the patient will not be communicating well. Any previous thyroid dysfunction? Was he on thyroid hormone before? Any radioactive iodine given? Any other medication like sedative medication, especially in elderly, they can dip them easily to myxedema state as well. This is just too quick to mention the hypothermia itself, but few reports mention myxedema coma can happen even in a summertime. Infection reported cases reaching up to maybe 80 or 70%. This is the most common presenting or precipitating factor is infection, whether they came with UTI or they came with pneumonia. This is the common infection have been quoted. Can have like stroke, congestive heart failure, trauma, drugs as mentioned a while ago. This is the one study I told you earlier. This is one of the biggest or largest number have been quoted. This is, in fact, this is as a national database in Japan. You know, the Japan, they are more advanced in technology in computerizing things in their health service. Imagine how many hospitals have been addressed in this national. It's 1,024 hospital during a period of 2 years. About 17 million patients have been admitted to this hospital, and what they quote how many myxedema coma have been proven or diagnosed. Only what they found 149 patients among 17 million who have been admitted to the hospital. So that really the percent you can find maybe 0.2 million. Who's non-survivor? It's 44. That means it's about 1/3 died because of this myxedema coma crisis presentation. They couldn't find much difference between survival and non-survival regard to the age, season of the admission, also a patient with oral thyroxine or plus L-thyronine, dosage of the thyroxine which have been used in treatment. Really what they found statistically significant is using of steroid or catecholamine. Also duration for the steroid days, if it's exceeding more than 14 days, get more statistical significant between survivor and non-survivors. Also in mechanical ventilation, that means these three or parameters, usually they are so sick patients. So this is what found in statistical issues. When they applied the logistic regression to these first parameter, they found again the age little between the code should 1.04, but what most striking is that who's using zero on, you can notice here it's a threefold patient. I mean, they can have high mortality. If you put catecholamine, what you call it, inotrope support, so it's reach six-fold, 6 times to be death rather than who have been using inotrope during admission. What about domestic scoring system? This is even if it looks an old or updated, this can guide you as a physician. If you find more than 60 score, this is highly suggestive. 25 to about 59 suggestive. If less than 5, unlikely. Their point regard to the temperature, also the CNS, if there is any obtundation or stupor. You can see these points. You have to then give you clue your patient is more prone to have this myxedema coma. It's matter of scoring, helping you, but again, you have to have low suspicion index when any patient present to the emergency with obtundation, hypothermia, bradycardia. There is another score, maybe it's easier than the previous one. They address the glaucoma scale and also the TSH value more than 30, less than 30, FT4, hypothermia, bradycardia. It's easy score. And his colleague, they found the sensitivity and specificity for this score reaching up to 80%. Treatment, it should be multidisciplinary as well. You shouldn't wait. If you suspect myxedema coma, the 3 or 4 modality treatment should be intensive care treatment with ventilator support. Fluid management is very crucial. Keep in mind the electrolyte disturbance, especially the hyponatremia. As you know, this is mostly as chronic hyponatremia. You don't need to over-treat hyponatremia, then you will develop what they call it stimulating syndrome and other stuff. So be careful about electrolyte disturbance. Aggressive managing the precipitating factor. Maybe I'll talk about the septic shock. Maybe they need a broad spectrum antibiotic waiting for the culture. Keep in mind this could be as an autoimmune. Maybe the adrenal has been affected. So you should deal with them as adrenal crisis, as mentioned by Dr. Salha. Again, thyroid hormone replacement. This is the calibrate of treatment, but keep in mind the other supportive is equal and important to treat your patient with myxedema coma or crisis. Treatment. Do take colleague. This is from an Indian hospital. In fact, the total of these patients, it's about 23 patients. 6 of patients, they have received IV, the remaining, they receive oral. The oral one, they give him 500 microgram loading, then followed by 150 microgram of maintenance dose. The 6 patients giving intravenously 200 microgram of L-thyroxine and maintenance of 100. What they found that there was no difference among the patient or the mortality. So equal outcome in mortality issue giving orally versus IV. This is one of the famous association, this ATA, American Thyroid Association, published in 2014. Again, nobody can give definitive treatment regime because of rare acute sudden only in what they can quote only the case report, case series. There is no much prospective study to be found. So this is their, strength recommendation. Loading dose of 200 to 400 microgram of levothyroxine, but keep in mind we want to give lower dose at 200, especially in older patient who's having history of coronary artery disease or arrhythmia. Then the daily replacement 1.6 microgram per kg per body weight. You have to cut down the dose if you want to for the IV 75%. Oral therapy or intratherapy can be given later on after the patient improve clinically. Giving the NG feeding, non-NG feeding, there is few case report support NG feeding can be work if you want to give orally. Just to keep in mind not to induce a vomiting, then there will be aspiration pneumonia. This is so it was strong recommendation, low quality of evidence. Giving L-theanine, the T3 can be adding not as a lone agent, can add it to L-thyroxine. Usually the loading dose 5 to 20 microgram with a maintenance of 2.5 to 10 microgram every hourly. Again, the same recommendation dose for the elderly patient who's having arrhythmia, and also therapy can be clearly recovery after giving the patient his consciousness. This is unfortunately it's a weak recommendation, low quality, but this is one of the big institution with the famous endocrinologists have been involved by writing this guideline. Maybe this is the last slide. Prognostic factor, older age, bradycardia, low T3, hypothermia less than 34, hypotension, sepsis, degree of consciousness. All these you can judge about your patient. The prognostic factor, is he going to be out of this highly comorbid disease, or he will be recovery and can be discharged. Even this, you can discuss the issue with the relative, because all the question, how he's going to be recovered, is there any, what's the percent? So keeping this prognostic factor, then you can deliver the message clearly to the family. This is the lady. This is really, it's a lucky person. She stay about 25. Then she just sent home only in a home oxygen. My conclusion or home messages: Mixed-coma is a rare entity. High suspicion is needed, as symptoms are usually vague and really it's non-specific. Mortality is still high. What we quote about 20%, this is the lowest can be found. Management need ICU setup, multidisciplinary team approach. Thank you for your kind attention.
Thank you very much, Dr. Douish, for your elegant presentation. And please be with us till the end for the question. Actually, we missed one of our presentation because Dr. Suhail Naam, he apologized because of sickness. So we came now to the last speaker, who was Dr. Bashir Aitani. Dr. Bashir is a consultant endocrinologist in Prince Sultan Military Medical City. He will give a talk about hypoglycemia in non-diabetic patients. So let's welcome Dr. Bashir.
Thank you, Anthony. Thank you for everybody, and good evening. We will talk about hypoglycemia overview. So, what is it, and why do we care about it? What causes it, and how do we diagnose it? What do we do about it, and how to prevent it? So, hypoglycemia is a syndrome.
Dr. Bashir, can you expand the screen, please?
Expand the screen.
F5 or the sign on the on the right side at the bottom.
Right side.
Yes, or press F5.
I'm pressing F5. Wait a minute. F5. Yeah. F5.
So do you see, just the on your right side at the button, the 69%, then after there is a sign, you could just press it and it will expand the screen.
I cannot see where I should go.
Yes, this one, yeah.
Yeah, it's okay?
Yes, thank you.
Okay, it's a syndrome characterized by symptoms of sympathetic nervous system stimulation of central nervous system dysfunction that are provoked by an abnormally low plasma glucose level. Hypoglycemia represents insulin excess, and it can occur anytime. So what is it? Strictly, hypoglycemia refers to a low level of serum glucose. It occurs when a mismatch of endogenous glucose need with exogenous and endogenous glucose availability derails the metabolic engine of normal glucose homeostasis. often defined as plasma glucose level less than 2.5 to 2.8 millimole, less than 45 to 50 milligram per deciliter. Hypoglycemia unrecognized by patient. Many episodes are asymptomatic. CGM's data showed that unrecognized hypoglycemia is common in people with insulin-treated diabetes. In one study, 63% of patients with type 1 diabetes and 47% of type 2 had unrecognized hypoglycemia as measured by CGMs. 74% of all events occurred at night. And in another study, 83% hypoglycemic episodes detected by CGMs were not detected by patients with type 2 diabetes. So 54% of hypoglycemic episodes were nocturnal, none in which were detected. So the physical examination, usually we have many common signs. The skin is moist, cold, hyperreflexia can be elicited. Hypoglycemic coma is commonly associated with abnormally low body temperature. Patient may be unconscious. As we know, this picture everywhere we can see it. These symptoms can be separated individually for each patient, and we can see depends on the severity of hypoglycemia. Many of this sign: shaking, sweating, anxiousness, dizziness, hunger, fast heartbeat, impaired vision, weakness, fatigue, headache, and irritability. So why we care about this hypoglycemia? Because hypoglycemia can kill. In the physiology, glucose is an obligate metabolic fuel for the brain under physiologic condition, while other organ can use other form of fuel like fatty acids. The brain cannot synthesize its own glucose. It requires a continuous supply via arterial blood. So as the plasma glucose concentration falls below the physiologic range, blood to brain glucose transport becomes insufficient for the adequate brain energy, metabolism, and functioning. Maintenance of glucose homeostasis, narrow plasma glucose range is normally maintained despite fluctuation of in food intake in physiology and in normal person and activity levels. Maintenance through diet, glycogen breakdown from the liver, and gluconeogenesis by liver and kidney. Usually they maintain this minimal level of glucose for the brain. Also, we have hormonal participation in case of decrease of insulin, increase of glucagon, epinephrine increase, cortisol increase, and growth hormone increase in many situations physiologically to maintain the glucose flow to the brain. Glycogen store can last 8 to 12 hours. Precursor for gluconeogenesis coordinated amongst liver, muscles, and adipose tissue. From muscle, we have the lactate, pyruvate, amino acid as substrate. And from adipose tissue, we have glycerol and fatty acids. The hormonal control, insulin inhibit glycogenolysis and gluconeogenesis, decreased serum glucose. Glucagon promote it's the opposite, glycogenolysis and gluconeogenesis to increase the blood sugar. Epinephrine limit utilization of glucose by insulin sensitive tissue. Growth hormone and cortisol also have a role during prolonged hypoglycemia. So what is the cause of hypoglycemia? We have two major etiological classes. First, the most important, increased insulin level. So over-medicating, insulinoma, and sepsis. And underproduction of glucose, medication, alcohol, salicylate, beta blockers, adrenal insufficiency, liver disease, malnutrition, and dehydration. Precipitating factor, irregular ingestion of food in diabetic patient, extreme activity without adequate preparation or food intake, alcohol ingestion, drug interaction, liver or renal disease, and hypopituitarism and adrenal insufficiency. The risk factor for hypoglycemia, age, duration of insulin treatment, strict glycemic control, as we saw in many studies, impaired awareness of hypoglycemia, sleep, history of previous severe hypoglycemia, and renal failure. So we have also many drug interaction, especially with type 2 diabetes and oral hypoglycemics, like warfarin and antiplatelet agent. So we have also known insulin higher dose or over treatment. Oral hypoglycemic in many conditions can leads to hypoglycemia. We have a lot of other agents which can be interfered with the oral hypoglycemic and leads to the level of the liver cytochrome and receptors and lead to hypoglycemia. In type 1, usually, as we said, insulin deficiency we have, and imperfect replacement leads to hypoglycemia, episode of hypoglycemia, epinephrine deficiency, minimal symptoms usually, hypoglycemia, and starting from minimal symptoms to hypoglycemia unawareness. In this patient also with the insulin deficiency, also we have glucagon deficiency. So all these factors can lead to continuous hypoglycemia or long hypoglycemia because there is no compensatory factor for this patient. We have also in diabetic patient treated with insulin or sulfonylurea, adjust the regimen, and usually there's a sign of hypoglycemia with individualization of the treatment will improve. In case of non-diabetic, we have to exclude the clinical problem like end-stage liver, renal disease, inherited metabolic disorder, sepsis, endocrine deficiency, non-beta cells tumor, prior gastric surgery, drugs, treat underlying disease, provide adequate glucose. In case of apparently healthy patient, the fasting should be measured if it's less than 50. Usually we need to measure the insulin and symptoms. If we have high insulin and high C-peptide, we need to exclude the insulinoma, autoimmune hypoglycemia, or factitious hypoglycemia by taking sulfonylurea by the patient. Or if the C-peptide is low, usually patient can be taking insulin exogenously, and this is a kind of factitious hypoglycemia. In case of sugar over 50 fasting, we need from the history, if we have strong evidence, extended fast, we will try to make it more than 72 hours, and to see if it's over 50, we go to this measurement of insulin, and if less than 50 and over than 50, we try to the mixed meal, and we check the Whipple triad. If we have positive, this is the reactive hypoglycemia, and if it's negative, the hypoglycemia can be excluded. So the Whipple triad: symptoms of hypoglycemia, low plasma glucose level, resolution of symptoms with administration of glucose or food. Symptoms are adrenergic, diaphoresis, tachycardia, anxiety, hunger, and neuroglycopenic from brain directly, dizziness, confusion, slurred speech, and seizures. The short-term consequence of hypoglycemia are cognitive dysfunction, behavioral abnormality, confusional state, coma, seizures, TIA, transient hemiplegia, and focal neurological deficit is rare. Long-term cerebrovascular event hemiparesis, focal neurological deficit, ataxia, chorioatetosis, epilepsy, rare. Vegetative states also rare, especially some in elderly with complicated cases, and cognitive impairment with behavioral and psychological problems. The acute complication of hypoglycemia, less than 3.3 millimole, result from exogenous cause, overdose of insulin, as we said, inadequate food intake, increased exercise, overdose of oral hypoglycemic agent, alcohol, and other agents like salicylate. The endogenous cause, insulinoma, neoplasm of beta cell, extrapancreatic neoplasm, hepatoma, tumor of GIT, inborn error of metabolism, fructose intolerance. Symptoms and signs of hypoglycemia are caused by epinephrine release, sweating, shakiness, headache, palpitation, and by lack of glucose of brain, bizarre behavior, dullness, and coma. The cause, anti-hypoglycemic mechanism are insufficient, the cause of unawareness. The mechanism of anti-hypoglycemic mechanism are insufficient in this patient. Hypoglycemia develop without warning symptom and sign. Pathomechanism involved in unawareness development. Primary defect is localized in central nervous system. Decrease or loss of neurotransmitter production of hypoglycemic stimulus, and decrease reactivity of peripheral tissue counter-regulatory hormones. Consequence, deep hypoglycemia, hypoglycemic coma, and death. The diagnosis by the history, drug use, infection, illness, hepatic, renal, cardiac surgery, laboratory tests, serum glucose, CBC, lights, BUN, uric acid, time insulin, and C-peptide. Other tests, ECG, and chest X-ray. The differential, neurologic, CVA, TIA, and seizure disorder, drug, alcohol intoxication, and psychosis and depression. The treatment, glucose, oral glucose, or IV dextrose from 5 to 20% solution, or 50% ampoule. IM glucagon, monitor glucose Q2 to 4 hours. If adrenal insufficiency, administer 100 milligram hydrocortisone and 1 milligram glucagon. If resistant hypoglycemia secondary to sulfonylurea, administer diazoxide 300 milligram over 30-minute IV Q4 hours and PRN. The treatment underlying problem, eliminate, reduce offending drug, resection of insulinoma, treat infection, education, how to prevent hypoglycemia, be aware of time of greatest risk, especially nocturnal hypoglycemia, individualized treat insulin therapy, take advantage of insulin preparation associated with less hypoglycemia nowadays, and ending or avoidance of fasting. Thank you.
Thank you very much, Dr. Bashir, for your excellent presentation. And I think there is an announcement from the, we came to the end of the program, so we'll come to the questions. But there is an announcement from continuous education that please share evaluation of this activity through the link. So there is a link provided. Please just do the evaluation so you can get the CME. Okay. So just I'm inviting all the panel now for the questions. So the first question to Dr. Salha. If the patient is presented with adrenal crisis and not known to have adrenal insufficiency, which better to start, either hydrocortisone or dexamethasone? because of the effect of hydrocortisone on synectin test.
Assalamu alaikum. Can you hear me?
Yes, yes. Dr. Salha.
The recommended steroid to treat the acute adrenal insufficiency is hydrocortisone because it's fast acting and it has the mineralocorticoid action. Regarding the investigation, you might be lucky and you have a chance to draw cortisol and ACTH level before starting the hydrocortisone, and you can interpret the result later on. But even if the patient receives IV hydrocortisone, once he's improved, he will be shifted to oral hydrocortisone, which is usually short acting. You can just hold the PM dose of hydrocortisone and do the morning level of cortisol, ACTH, and synectin test before the morning dose of hydrocortisone. So you'll be sure that your synectin test will not be affected. Alternatively, you might give dexamethasone, but which with a dose of 4 milligram IV bolus. This is the equivalent dose of 100 milligram hydrocortisone. But in these cases, you need to be more aggressive with IV fluid management, and you need to be very careful in electrolyte management. You need to manage the hyponatremia and the hyperkalemia if it's present, because there is no mineralocorticoid activity in dexamethasone. However, if the patient really in the severe form of the adrenal crisis, better to give him hydrocortisone as life-saving medication than to investigate him later on once he is on oral hydrocortisone.
Thank you very much, Dr. Salha, for your answer. So a question to Dr. Nasser.
Do you mind if I add something to that? I think to the questions, I think the most important in this endocrine emergency is to suspect and treat and diagnose later. You will not harm the patient if you give him IV hydrocortisone and IV fluids, and later on you investigate for adrenal insufficiency if you missed doing the serum cortisone and ACTH before the patient was given hydrocortisone. So yes, both will work, but I think the priority is not to wait until you get the result or not to wait until you draw the blood. Treat if you suspect, if index of suspicion is high, and then confirmed later. Treat, confirm later.
Thank you very much for your comment. So there is one question here. Is subclinical hyperthyroidism a risk factor for thyroid storm?
No, I mean, if you look into this American, I call it the American and Japanese diagnostic criteria, a prerequisite for this to apply is a severe thyrotoxicosis. So your T4 must be elevated, your TSH is suppressed, your T3 may be elevated, may be normal. So T4 should be high, TSH suppressed. So I've not come across any patient with thyroid storm with subclinical hyperthyroidism. For the audience, subclinical hyperthyroidism means that your TSH is suppressed, but your T4 is normal. So usually your T4 will be high, unless we are talking about somebody who's quite sick for a long period of time, that he shifted from the thyrotoxicosis to the sick euthyroid, where his T4 and T3 is low. But usually severe thyrotoxicosis is there before. But I'm not saying that the T3 and T4 should be on the roof. No, I mean, there is overlap between the thyroid storm, the thyrotoxic patient, which is uncomplicated, and the thyroid function. Though there is no a set of TFT that you say this patient is having thyroid storm or this patient is having thyrotoxicosis. But subclinical hyperthyroidism, I don't think so. I hope that my answer is clear.
Thank you very much. Really, it's clear. Okay, thank you. So a question to Dr. Dawish. This is from Ruqayya. Does the level of TSH correlate with the symptoms of patient presented with mixed edema coma? And she just commented that sometimes we see patient with, with high TSH, which is like in 100, and very low free T4 without myxedema coma. What is the explanation for such observation?
Sure. Thank you for the question. In fact, unfortunately, yes, you can have, lowish FT4, high TSH, but they can present with the storm, different than the scenario what Dr. Nasser has mentioned for storm, thyroid storm. But myxedema coma, yes, don't be fault. You need to have sky high TSH, severely low FT4. No, this is not the picture, unfortunately. That's why we have to have high suspicious index and to pick up this myxedema coma. Yes, we are, the common scenario, we are admitting patient for thyroid cancer doing withdrawal, not to give the thyroid, the TSH analog, and you can see the FT4 point sometimes 5 to TSH more than 100. But I think this is only for a few weeks, like 4 to 5 weeks. Allah subhanahu, they create adaptation mechanism to our body. But definitely, if the patient progress further, yes, he can go to thyroid storm. One case report I quoted, patient diabetic, type 1, subclinical hypothyroidism, came with DKA. He went for myxedema coma. How does it explain? This is just one case report, but keep in mind, precipitating factor is usually the leading for most of myxedema coma rather than cut value of TSH or cut value of FT4.
Thank you very much, Dr. Mohammed. So a question to Dr. Bashir. How to diagnose in non-diabetic patient sulfonylurea drug intake if there is no assay? And this is from Dr. Ibrahim Mukhtar. And he wrote, what about the use of octreotide in refractory sulfonylurea-induced hypoglycemia?
Yeah, I saw that question. Thank you, Arman. For the first one, I think C-peptide is a guide for us. When it's low, it means there is no stimulation of this peptide, and we need to suspect that. We need to keep the patient on fluids and rehydration until at least 48 hours, then to see if we have no renal problem. If we have, and for the severe hypoglycemia due to sulfonylurea mainly, usually these patients are renally impaired. And I don't have the experience with octreotide, but my experience is with 1 or 2 sessions of dialysis, they solve the problem, especially when this severe hypoglycemia is recent and not from at least one or 2 weeks by accumulating the sulfonylurea in the blood, because the mortality will be very high, and I saw such case before. So I think 1 or 2 sessions of dialysis can solve this problem, because these patients are usually they have renal problem, renal impairment or renal insufficiency.
Thank you very much, Dr. Bashir, for your answer. So a question here to Dr. Salha. How to assess recovery of hypothalamic pituitary adrenal axis after prolonged use of steroid?
Okay, this is a very interesting question. We face this problem mainly in a patient on long-term immunosuppressive medication, like rheumatology disease or organ transplant patient. There is no clear answer to this question, but the usual recommendation to keep on tapering of the dose which the patient on. Usually they are on prednisolone 40 or 60 milligram. So keep on tapering of the dose until you reach the minimum dose, which is 5 milligram prednisolone. Once you reach this level, 5 milligram, shift the patient to the short-acting steroid, which is the hydrocortisone. So the patient can be shifted to hydrocortisone 20 in the morning and 10 in the evening, or 10-5-5. Then you can gradually taper off this hydrocortisone dose, like to the lowest dose, which is a total of 15 milligram a day. You might keep the patient on this dose for 2 or 3 months to enhance the recovery of the hypothalamic pituitary adrenal axis. Then you can hold the PM dose of the hydrocortisone, which is usually the 5 milligram, and do morning cortisol. If the morning cortisol is below 100 or 80, most likely the axis didn't recover, so you need to continue on oral hydrocortisone. If the morning cortisol more than 415, most likely the axis is recovered and you can safely stop the steroid replacement. If the cortisol level in between 80 to 415, you need to do the Sinexin test. If the peak level of cortisol more than 500 or 550, you can safely stop the hydrocortisone, but if the baseline level in this case is low, you need to still supply the patient with the cortisone dose during the stress. I hope this answered the question for you.
That's really
That's
an excellent answer. Thank you very much, really. So there is one question to Dr. Douish from Dr. Hamad. If my patient with hypothyroidism came to my clinic with decreased cognitive function, it was a gradual decrease over weeks. Should I ask for thyroid function test in this situation and wait for the result, or empirically raise the dose of thyroxine and wait for the result later on?
Sure. Thank you, Dr. Ablani, for this question. Because you raised the issue that I forget to mention in maximum coma and ICU setting. There are some suggestions that if you want to see how the patient progress, you can request mainly the FT4 every 2 to 3 days, just to see the trend. But definitely the TSH, it will lag behind it. Again, as outpatient, if you want to start patient or he was missing the dose, giving L-thyroxine, the ideal we need like to 4 to half-life of L-thyroxine, then you can check it. I mean, half-life of L-thyroxine is 1 week or 6 days, check it 4 to 5 weeks. But if you want to see the effect of your medication, yes, you can request every 10 to 14 days. Again, the FT4, keep in mind, TSH, it will lag behind, it will take weeks to months to be recovered and come down to the normal range.
Thank you very much, Dr. Muhammad, for your answer. So there is a question to Dr. Nasser. In treatment of thyroid storm, if the patient is having an obstructive airway disease and beta blockers contraindicated for him, what other options should we use?
If the beta blockers is contraindicated, then the calcium channel blockers is an alternative. Short answer.
Okay, thank you very much. So not all of them, isn't it? Or
sorry?
I mean, not all calcium channel blockers.
No. If we are saying the beta one, it can be used in this situation. But if there is any concern, then the calcium channel blockers is the second choice. Yes.
Okay, thank you very much. So a question, and I think this is the last question to Dr. Salha. Can you, from Dr. Ibrahim Salama, he's asking about the main clinical laboratory differences between adrenal insufficiency and this IADH syndrome.
Okay. Just to make it clear, the cause of hyponatremia in the cases of secondary adrenal insufficiency is decrease the osmolar threshold to which the AVP will be released. Like cortisol deficiency will increase the antidiuretic hormone release. So more or less, it is like the syndrome of inappropriate ADH, exactly like laboratory-wise, the patient will be hyponatremic, low serum osmolality, the urine osmolality will be high, and the urine sodium will be high. They are exactly the same. It's only the clinical patient with acute adrenal crisis will be hypotensive, and he will have the other part of the sickness syndrome related to the adrenal insufficiency. And please keep in your mind, you will never diagnose syndrome of inappropriate ADH secretion unless you rule out adrenal insufficiency. One of the criteria to diagnose ADH is to rule out adrenal insufficiency, because laboratory, they are the same.
Thank you very much.
There is one minor thing also that in adrenal insufficiency that you will see a prerenal azotemia, which is not the case in SIDH, that the urea and creatinine will be low. And also if you ask for uric acid, it will be on the low side. So in summary, the SIDH is too much fluid for the sodium. In the adrenal insufficiency, the fluid is too low and the sodium is too low too.
Yeah, true. Thank you, Dr. Kat.
Thank you for the contribution. So the last question here from Dr. Ibrahim Mukhtar to Dr. Douish and Dr. Nasser. Does subclinical hypo or hyperthyroidism has any risk for patients going to thyroid or non-thyroid surgery? So he's asking about subclinical hypo or hyperthyroidism. And he's asking about the risk. I mean, if the patient is going to thyroid or non-thyroid surgery, the risk of thyroid storm or myxedema.
Okay, I'll take that. Okay, I will leave the easy one for Muhammad, the subclinical hypothyroidism. But the subclinical hyperthyroidism, if the patient is going for urgent surgery, by all means can go. And if the patient having manifestation of subclinical hyperthyroidism like tachycardia, etc., then beta blockers, I think the cornerstone for this management. If it's elective surgery and the patient can wait, we can repeat the thyroid. First of all, we have to know if this is transient or permanent subclinical hyperthyroidism. But in reality, in clinical practice, yes, we can go for urgent or emergent surgery, but the routine surgery would like to know why the patient is having subclinical hyperthyroidism.
Dr. Douish?
Yeah, sure. This is a really nice interactive session. Dr. Nasser is a really academic guy. You can see he's anytime he can interfere and did a comment in a proper timing. For subclinical hypothyroidism, that mean normal 54 high TSH. Definition, people said up to 10, up to 15 TSH, this is called subclinical. But when you reach 20 of TSH with normal 54, maybe the definition is changing, or you cannot say subclinical hypothyroidism. General rule is all patients who should go for surgical procedure should be clinically and biochemically thyroid. But in case of high TSH with normal 54, yes, can be safely going to the surgery. Keep in mind which type of surgery, type of anesthesia, patient, is he waiting for to do this surgery as semi-elective, semi-urgent? So a lot of parameters, then you can judge about your patient, not simple subclinical or even subclinical hyperthyroidism. Shall I do surgery, not doing surgery, based on patient situation, his comorbid illness as well. Then we can proceed for managing your patient.
Okay, thank you very much. I think there is one more question here to Dr. Nasser from Dr. Abdurrahman Al-Shitri. What about reserpine, drug in thyroid storm?
Reserpine and thyroid storm, what is it?
So reserpine, actually, I'm just
What is the question?
Can it be used in thyroid storm management for those with for those with beta blocker, I mean the one with contraindication of beta blocker.
I mean, we said that.
Reserpine?
Okay. We said that, I mean, beta 1 or beta 1 selective, there is no problem to use. If there is any problems, the calcium channel blockers, I don't have any clues about Reserpine in as rate rhythm control. I don't know about that.
Okay, thank you, Fair. Thank you very much. So we came to the end of the session and our mini symposium. So I would like just to remind all the audience to do the evaluation of the activity, which is really important for their CME. And finally, I would like to thank all the speakers for their contribution and their elegant presentations. I'd like also to thank the postgraduate and continuous education for their role. And it was really very important role. Without it, we couldn't do this mini symposium. And finally, I'd like to thank Dr. Dawish and the pharmaceutical company Novo Nordisk for sponsoring this event. I wish you all the best. Thank you all.
Thank you.
Thank you.
Thank you very much. See you.